Hi, it's Kristen here at UT Southwestern. Thank you for joining our Facebook Live chat on migraine triggers. Today we're going to be chatting with Professor and neuro-ophthalmologist Dr. Deborah Friedman. Dr. Friedman is director of UT Southwestern's Headache and Facial Pain Program. She's certified in neurology by the American Board of Psychiatry and Neurology with subspecialty certification in headache medicine by the United Council for Neurologic Subspecialties. She's also affiliated with the Peter O'Donnell Jr. Brain Institute here at UT Southwestern. So we're excited for this chat. As usual, don't forget to share it with your friends, ask comments in the comments section. Any questions that you have, we'll take as many as we can get to, and we're going to go ahead and get started. So Dr. Friedman, thank you for joining us.
You're very welcome. Thank you for having me.
Absolutely. So we hear a lot about migraines, maybe not so much about triggers, but what is a trigger?
A trigger is either something you're exposed to or something that is taken away that provokes a migraine, and the time window is a little nebulous. So there are some publications that say it's within 48 hours. There are other publications that say it's within 24 hours.
Okay.
But it's certainly within a day or maybe two.
Okay. So even kind of more basic than that, how can somebody tell if they have a migraine versus a headache?
So a migraine is more than a headache, right? So many people with migraine will start to have a sensation that they're going to get a migraine even a day beforehand. So they may have unexplained increase in thirst or unexplained urination or food cravings or a mood change. Either way, either euphoria or even depression. And a lot of people don't realize that this is what we call the premonitory symptom or the prodrome of a migraine. Migraine sometimes is associated with aura. Usually it's visual, seeing flashing lights or missing part of your vision. And then the headache is usually moderate to severe in intensity. It's often throbbing, pounding, pulsating, usually builds up in intensity, and people are generally either sensitive to light, sensitive to noise, they have nausea or vomiting, and usually this pain gets worse with movement. So most people prefer to lie down. Okay. The pain goes on for at least 4 hours in adults, at least 2 hours in kids. It can last up to 72 hours. And once it's over, most people are not really ready to just jump back into it. Often for several hours to a day afterwards, they have what's called the postdrome. They're kind of tired, they may have some residual pain, residual nausea.
Okay, good to know. So our questions are starting to come in. Before we get there, if you could explain kind of what are some of the common triggers that people should know about?
So hopefully I'll remember them all. The ones that are probably most common, starting with the environment, are changes in the weather, which is a little controversial, but people all over the world report this. Exposure to bright light, like sunlight, and exposure to heat is often mentioned as well.
Interesting.
Occasionally people will say cold, but usually people will talk about being out in the hot sun. So that's a pretty common one. Odors are very common, and this is a huge problem in the workplace in particular. So, you know, here at UT Southwestern, there was actually a policy that came out within the past year or so saying that no more perfume, no more cologne, you got to stop wearing this stuff to work. Problem is the patients still wear it, so we all get exposed to it. But perfume is common. Other scented products like lotions or the cleaning fluid that they use to clean the workplace with, gasoline, kerosene, cigarette smoke is a huge one as well. Often triggers migraine. What else? Other visual stimuli like flashing lights, strobe lights, driving through the trees and having the light kind of shining in and out will often trigger migraine. Change in sleep pattern. So migraine loves change. So we'll get on to the change stuff, right? So one of the more common ones worldwide is a change in sleep pattern. Either not getting enough sleep, sleeping more than one usually does, or totally shifting your sleep pattern, like having jet lag. So that's a problem too. So keeping a very rigorous, pretty strict sleep cycle, trying to go to sleep around the same day, around the same time, getting up around the same time, that really helps.
So that has to be hard for those people that are shift workers that may work days and then they work nights and then they work days.
Absolutely.
That
Absolutely.
sounds wonderful.
And for our residents, right, who are doing night float and keeping all these unusual hours. So
Right.
yeah, it's sort of an occupational hazard in a way for a lot of people.
Right. Well, so Raina has, or Radia, excuse me for mispronouncing your name. Her question is, do you think children have migraine?
Absolutely, absolutely. So migraine affects, in North America anyway, migraine affects about 18% of women, about 10% of men, and about 8% of children. And
Wow.
children have symptoms just like adults do. They often can't verbalize them as well as adults can, so sometimes it helps to have them draw a picture of what they feel like during a migraine. But they generally last a shorter amount of time than adults, so it's 2 to 72 hours for children. And often in kids, vomiting helps. Sometimes in adults too.
Oh.
So they frequently, if your child has a headache where they just want to go lie down in a dark room, don't bother me, can't play with their phone or their video games, and has to retreat and starts vomiting, okay, chances are that they have migraine if it's a recurrent pattern.
Okay, good to know. Great question. Thank you for joining us. We have a question here from Christy, and it's, do hormones have an effect on triggering migraines?
Sure do, in women in particular. So anything, remember migraine likes change, so anything that causes your hormones to fluctuate can potentially trigger a migraine. And for women, that's most commonly the menstrual period, because there's a rapid decline in the estrogen right before the bleeding starts during menses. And so it's a very, very frequent time for women to get headaches. Pregnancy, another big time with hormonal change, right? Many women with migraine have an improvement in their headaches during pregnancy, usually in the second trimester. But that's not always the case. And there's some women that actually only get aura during pregnancy. They never have it at any other time. And then the next biggie is, well, there are two I missed. One is menopause, right?
Okay. Yes.
So in the perimenopausal period, when the hormones are doing all kinds of crazy things, right? Migraine can do all kinds of crazy things too. For a lot of women, it settles down after menopause. And then going back to the other end of the spectrum, menarche, when menses first starts, a lot of girls will start to experience migraine around the time they start getting periods.
Okay, that makes sense. Great question, Christy. Thanks for joining us. Here's a question from LaShandra. It's, I'm a migraine sufferer and have been told that a deficiency in magnesium can cause migraines. And I've noticed that since taking a magnesium supplement, that's helped. What are your thoughts on magnesium?
There are some studies that show that in certain patients with migraine, they don't fall into one particular category, that there can be a decrease in serum magnesium. That said, it's hard to accurately measure serum magnesium. So we routinely put our patients on magnesium supplements if they're interested in going that route.
Interesting. Okay, great question. Thanks for joining us. So here's a different question from Christy. Can exercising harder than usual lead to migraine?
It potentially can, and there's a theory that was just published in a recent edition of the journal called Headache, where they were looking at they called it sort of the surprise element. And it's not that you're aware of being surprised, but it's that your body is going through something that's different than normal, right? So maybe you could drink a cup of coffee every day and you're fine, but if you drink 4 cups of coffee, that's not so fine, it triggers a migraine. I suspect that exercise could do it too, but also keep in mind that exercise can be associated with dehydration, right? And getting overheated. So both of those things are on the list as well.
Okay, great question. Here's a different question. Here's one from Jenny, and she says, Dr. Friedman, I've always heard migraines are like mini strokes. If so, am I at greater risk for strokes if I have migraine? Will strokes give me migraines now? A couple different questions. So let's start with the first one. Is somebody who has migraine at greater risk for stroke?
People who have migraine with aura are at a higher risk for stroke. And this has been, again, shown in numerous big population studies. They're relatively old studies. But the highest risk seems to be in women who are under the age of 50 in which case the risk of stroke is low to begin with, so don't panic too much. They have twice the risk of stroke as women who don't have migraine with aura, who are under age 50. And if you start adding other risk factors to that, like cigarette smoking, using birth control, family history of stroke, heart disease, etc., then that risk really, I think, amounts to something substantial. So, in general, the risk is very low, just looking at the overall number of people under age 50 who get a stroke.
Okay, good to know. Great question, Jenny. Thanks for joining us. So we have a bunch of different ones coming in. Thank you so much for all the questions. Here's one from Bridget, and this one is, do you and UT Southwestern plan to research the benefits of medical marijuana for chronic intractable migraine?
This is Texas, darling. So I like my medical license.
Yeah.
There is actually currently no medical evidence that is available indicating that marijuana is helpful. And until that happens, until it's legal in the great state of Texas, we will not be doing that in my division at UT Southwestern.
Yeah, that's really great question. We're glad you joined us. Thank you.
Probably not what you want to hear, but that's all I can say.
That's where we are. So, all right, we've got some more coming in. So, from Jenny, what can lessen the occurrence, duration, and severity of ocular migraine?
Well, Jenny, first we need to know what you mean by ocular migraine, because there's really no diagnosis of ocular migraine. It's used incorrectly by many people, including physicians. So I'm assuming that you mean aura without headache. And the aura doesn't come from the eye, the aura comes from the brain. That's why it's not ocular. The only way to really reduce migraine aura is by taking something for prevention. Because once you get the aura, there's really no way to get rid of it. It's kind of got to run its course. So there are a lot of different things that we use for prevention, and it's just a matter of finding out what works for you.
Okay, good question. So we talked a lot about some common triggers earlier. What are maybe some not so common triggers that people might not think about?
We haven't even finished the common ones yet, but anyway, sometimes it's just really hard to figure it out at all. So, there's this whole category of food and alcohol. So alcohol is pretty well established trigger, especially wine and beer and some spirits. Apparently gin and vodka are less likely to. But I suspect tequila, which is a Texas favorite, is probably in the bad list. You know what tequila does. Anyway, and the worm may be on a bad list too. Okay, so back to food. Beer and wine pretty much are pretty well accepted as being triggers. They're not triggers for everyone. Some people find they can drink a little, just not a lot. It's really up to the person. And then there's this whole concept of food triggers, right?
Yeah.
So the famous one, I'm sorry to say, is chocolate. It's not really clear whether people who think chocolate triggers their headaches are actually getting their migraines because they ate chocolate, or because they had, remember the prodrome, the premonitory phase, food cravings. What else are you going to crave besides chocolate? Not lima beans, not cauliflower, right? You got to crave something good.
Yeah.
So a lot of people will eat the chocolate because it was part of their migraine prodrome, and then they get a headache anyway. Other things that are been implicated are aged products, because the theory is that they accumulate this chemical that's called tyramine that naturally occurs in food as it ages. So aged cheese, aged fruit like guacamole, which is overripe, avocados, overripe bananas, anything that's a little past its prime can potentially do it. Dried fruit can potentially do it. Aged meat, like smoked meat, cured meat, luncheon meat, stuff like that. That's all on the list. What else? MSG, monosodium glutamate, very well established actually. And MSG is tricky. You have to really be a detective to find MSG. It's in a lot of ethnic food. It's famous for being in Chinese food, but a lot of Chinese restaurants don't use it anymore. But it can be put in all different kinds of ethnic food, including pizza sauce.
Oh gosh.
I've heard that it gets, I don't know if people still do this, but they used to spray it on the salad bar at restaurants because it keeps the greens looking green.
Fresher.
And it is often included in other kinds of food, and they'll call it a flavor enhancer, or artificial flavorings or other natural flavorings, and you just have to really be a detective for that one. Aspartame can sometimes be a problem for people. It's a diet product, diet soda often contains it. Certain nuts can be triggers.
Oh, gosh.
And then there's all these other weird food additives that you just kind of have to be a detective and start keeping a diary and see if you can find any correlation between, what you happen to eat and whether you got a migraine. And there are lists that you can find online of purported triggers.
Interesting. That's a lot of triggers.
Yeah, and that's not the uncommon ones.
Yeah, I know. So we've got a bunch of questions in here, including a couple from Amanda. She's wondering, are there any known vascular mutations related to the occurrence of migraines? And the second question she had, does the etiology differ for each person?
Well, we're not sure what the etiology of migraine actually is.
Okay.
So there's probably a genetic predisposition to migraine, and with rare exceptions, which are the types of migraine where you get weak, it's called hemiplegic migraine, there's no specific gene that's ever been found that accounts for everybody with migraine. Okay. It's probably a combination of different genetic variables that does it. And we certainly hear about a family history of migraine in most people who have migraine. There's no particular vascular abnormality. Migraine used to be thought of as a vascular, quote-unquote, headache, but it's really not. It starts in the nervous system, and there are vascular changes that occur as part of the migraine process, but that's not the initial abnormality that's causing the migraine.
Okay, great questions, Amanda. Thank you for joining us very much. We've got a different question from Christy, and we've talked a lot about what some of the triggers are, some of the issues with migraine. She wants to know, what are some natural remedies for migraine? She's heard that side effects from migraine medications can be brutal.
Well, Christy, in defense of migraine preventives, you don't know till you try, and everybody's different. And, I've had patients in my practice that were so reluctant to take specific medications because they were afraid of what they would do to them. And once they actually agreed to try, they found that the medication worked very, very well. Okay. And everybody is different with regard to how they react to medications. There are some natural things that can be tried. One is riboflavin, or vitamin B2. These all have similar doses, so they're easy to remember, which is about 300 to 400 milligrams a day for all of them. The next one is coenzyme Q10, which the dose is about 300 milligrams a day. And the other one, as previously mentioned by our former caller, is magnesium. And the one that was studied is magnesium oxide, again, around 300, 400 milligrams a day. But if you can't tolerate magnesium oxide, it can cause gastrointestinal distress. Sometimes it causes diarrhea. So if you're constipated, it's a good choice. But if you can't tolerate magnesium oxide, then there are other forms of magnesium, like magnesium gluconate and others that people sometimes will use. Feverfew is natural. That's been out there for a long time. The data they're okay on feverfew. It's an old compound. Some people find it helps. And then there was another product that we highly recommended until we found some problems with it, which was called Butterbur. And the problem is that some people who were taking Butterbur for prevention, even though it worked well, they developed pretty bad liver toxicity. So officially, as a specialty, we have stopped recommending Butterbur for that reason.
Okay, interesting. So you've got some options there, Christy. Thanks for joining us. Here's a question from Bridget, and this one is for individuals that have migraine consistently and you have pain medications. What plans do you have to help with abortives versus preventatives in terms of migraine medication?
Probably everybody with migraine needs a good abortive or acute medication, at least one. Many people also need medication for nausea, which unfortunately is not probably prescribed as much as it should be, because nausea can be the worst part of it for some people. And then the criteria for prevention are pretty loose. So the official criteria are at least 4 migraine days a month. But it can be fewer than that if you have a lot of migraine-related disability, if you're missing work, if you're missing life, then we can consider it with fewer than 4 days a month. People who have specific types of migraine, migraine with brainstem aura, which is signs or symptoms that come from the back of the brain, like being off balance and slurred speech and double vision and sometimes even loss of consciousness.
Okay.
Hemiplegic migraine, the one with the weakness, everybody should be on prevention regardless of how frequently they have the headaches. What else? Migraine that does not respond well to acute treatment. We would think about prevention as well.
Okay, good question, Bridget. Thanks for joining us today.
And P.S. prevention is also markedly underutilized. Study after study shows that most people who should be on prevention are never even offered prevention.
Oh wow, that's problematic.
It is.
Okay. All right, so we have a question here from Carter. If I suffer from abdominal migraines as well as head migraines, will treatment for one also treat the other?
It often does. And often people with abdominal migraines, which means they get episodes of pain in the abdomen, which may or may not be associated with vomiting also. They often end up, seeing the gastroenterologist and going through all these tests and treated with GI drugs, when in reality, migraine drugs usually work. So the triptans frequently work for acute treatment. This is off-label, but I've heard from some of my colleagues that even onabotulinum toxin or Botox has worked for some of his patients with abdominal migraine. Okay, and that's injected in the head. It doesn't go anywhere near the abdomen, so I think that tells you where the problem's coming from.
That's interesting.
Yeah, isn't it?
Wow, great question. Thanks for bringing that up. So, for those who have migraine, how do they determine what their triggers are?
Well, it can be hard. There are apps that can help you.
Oh, okay.
So that has, technology really has made a difference. There are, I don't represent any of these people, and I'm sure that I'll forget some because I don't know all the apps. But there's one that's called Curalator, and that's actually why they developed the app, was to study migraine. And so some of the things that are in the literature about triggers come from Curalator. There's also an app that a lot of my patients like, which is called Migraine Buddy. There's, I think, eye headache, letter I, not E-Y-E. I would say just go online and find one that seems to work for you.
Okay.
It requires some diligence on your part, and a lot of people really are not into being that OCD as to, tracking every single thing they eat and every single time they get a migraine and how long did it last, and, then trying to research back and see what caused it. But I think that's probably the most humane way to find out if you have a trigger or not. Okay. The other option is basically going on an elimination diet, which means cutting back like everything that tastes good from your diet and living on rice, and then starting to add things in. And as somebody who enjoys good food, I just can't, in my heart of hearts, really put people through that. But some people find that it really helps them figure it out.
Okay, good to know. That's a really big ask to give up stuff, but I know people do
it
often.
If you're in that much pain and it's disrupting your life, then some people will do whatever they have to do. I understand that.
All right, so we've got only a couple minutes left, so we're going to take a couple questions, and then we're going to let Dr. Friedman go back to our day. Here's one more question from Bridget. What about thoughts on this, and I'm going to mispronounce this, it's CEFALY device.
It's called the Cephaly device. There are currently multiple devices on the market that are used to treat migraine, and they can be used either as prevention or they can be used symptomatically. Cephaly was the first one that came out. It's a stimulator that is applied to the forehead. It applies a low current of electrical stimulation, and it stimulates the supraorbital nerves, which are the nerves that kind of supply the forehead and the front part of the top of the head. And some people find that it's very helpful. There's another device that is called the non-invasive vagus nerve stimulator. It's marketed as the gamma core device. I think we talked about it once when we talked about cluster headache, but it also is useful for the acute treatment of migraine. It's currently being studied in the United States for the preventive treatment of migraine. We're actually doing a trial here, but it's on the market in Europe for prevention. And that delivers current over to the vagus nerves and travels through the neck. The third device is called transcranial magnetic stimulation. It applies magnetic waves basically to the back of the head. And so patients can deliver a single pulse of magnetic stimulation and repeat that several times during the day as needed, for both acute and preventive therapy. There's another device that will be coming out. It's not out yet. It's called the neuro device, and it's non-painful remote stimulation. So the device actually goes under the arm, and it provides stimulation on the arm, and it's controlled by a cell phone. It's very clever, actually. It's not painful stimulation, but it probably interrupts the pain pathways as they're going up to the brain, and distracts them. So they are not quite so sensitive to painful stimuli.
Wow.
So they're planning for that device to be on the market in the United States in probably the fourth quarter of this year.
Okay, good to know. Great question, Bridget. Here's our final question. This is from Amanda. So thank you for joining us. And if you can't identify your triggers, do you have any recommendations outside of episodic medication management?
Well, first of all, even though we're talking about triggers, don't get too hung up on triggers.
Okay.
Probably, they say 80% of people with migraine can identify at least one trigger. Excuse me, in my practice, I would say it's less than that.
Okay.
So not everybody has triggers. And there's some people, I think, that sort of take it to the extreme with triggers. Like, they ate something once and they happen to get a migraine, and so now they're never going to eat that again. And this leads into this whole cascade of emotion and anxiety, and people end up living in a cave because they're afraid to do anything. So I think you kind of have to be a little rational about it as well.
Okay.
But basically, what else can you do? You can lie down, you can use heat, you can use ice, you can use one of these devices. So yeah, there are some homeopathic things that can be done besides taking medication. But if you're really having a lot of severe disability from your migraines and you can't function, regardless of your philosophy, we do have really good treatments out there. So I really recommend that you see a neurologist or see a headache specialist, and we can help you. It's a very treatable disease, which is what makes it so much fun to do headache medicine.
Awesome. Well, I think we're all out of time. I want to thank you, Dr. Friedman, for joining us, answering all these questions. I want to thank our audience for joining us and for all the great questions you shared. The chat, as usual, it'll be here on Facebook, but we're also going to upload it to YouTube later this afternoon, so you can watch it there. And I want to thank you for your time. Have a great day.
And have a happy Migraine Awareness Month.
Good plug.